Good morning, everyone. Thank you so much for the honoring invitation. So, intravascular ultrasound imaging was initially introduced by this gentleman, Dr. Paul Yock from Stanford, California, and this is the original publication in the Journal of the American Society of Echocardiography. Since then, and through numerous randomized trials and meta-analysis, IVUS has proven to be, when compared with angiography alone, a better way to improve MACE and outcomes. When we do IVUS, we do before a procedure, during a procedure, after a procedure, and sometimes during follow-up. And also, when we perform an IVUS examination, we have to give a comprehensive report. What can you see with IVUS? We can appreciate, of course, all the three layers, as you see here, of the arterial wall, meaning a small part of the adventitia, this black layer here, which is the media, and the intima. And what is inside the intima and the lumen, it's most of the times the plaque. Let me remind you that IVUS methodology is a pullback methodology, meaning that you use a manual or a motorized pullback method, and from the distal part of the vessel, you come back to the proximal, and you get frames, steel frames, slices of the artery or of any vessel that you perform the exam, and you see at the center here the IVUS catheter, around the catheter the lumen. Here is the three layers of the wall, the adventitia, this black here is the media and the intima, the plaque, and of course, you can do some measurements. You can draw some circles. You can circle the lumen area here, the vessel area, and what is in between is the plaque. And by these measurements, you have to do the report. So, how we do the report? You have to pick the reference segments, meaning the proximal and the distal reference. What is the distal reference? It's the most normal, the most healthy looking site within 5 millimeters of the stenosis. And the proximal reference, the most normal looking site within 5 millimeters from the stenosis, again. And you do the measurements, the lumen measurements and the vessel measurements. And the most important one is what we call the minimum lumen area, meaning this circle inside the lumen. And also, you get the minimum stent area and the diameters, the minimum lumen diameter, the minimum vessel diameter, the maximum lumen diameter, and the maximum vessel diameter. And based on that measurements, you see IVUS gave us the criterion of a significant stenosis for major epicardial arteries. And this is the cutoff of 4 square millimeter, except left main and SVGs. Of course, there is a lot of criticism about this cutoff point. However, when we are in the left main, there is another number for significant stenosis. This is the 6 square millimeter. And when you are in a left main case, preferably you should use IVUS from both the LAD and the circ, because that way you can appreciate the pattern of the disease and then to have an accurate estimation of which treatment you should follow. That is why we call the IVUS for left main cases is the game changer. So when you place a stent, then you have stent measurements, meaning the minimum lumen area inside the stent. The minimum stent area. And when you have this measurement, the minimum stent area, you can appreciate stent expansion, stent expansion, and stent symmetry. In the literature, you can find numerous of data regarding the optimal stent expansion. And what is this? Is it something that we get? Is it something that we look? Well, usually the principle is to get the stent minimum stent area as big as you reasonably can. And currently, with the second and the third generation of DES, we are seeking something for 5.5 square millimeters. When you are in the left main bifurcation, then the numbers are different. 7 square millimeter for the distal part of the left main, 8, as you see, for the body of the left main, 6 for the LAD ostium, and 5 for the circ ostium. Malapposition. When you place a stent and you do IVUS afterwards, you can see if the stent touches the vessel wall. And if not, this is called malapposition. Acute malapposition is not a problem because it can be easily solved by high-pressure balloons. Late acquired malapposition is something that we used to see in the past, not these days, but this is the problem. If you see it, then it's a predisposing factor for late acquired stent thrombosis. Also, by IVUS, you can see the plaque and what we call unusual plaque morphologies, like an ulceration or erosion or a plaque rupture, and then aneurysms or pseudoaneurysm. You can see here, this is a typical plaque rupture. There is a cavity, there is a thin cap right here. The thin cap is broken and there is accumulation of blood inside the cavity, and this is how it looks like by the angio. And this is a true aneurysm. What does it mean, a true aneurysm? All the three layers of the arterial wall, you see, are included in this enlargement, actually, of the artery, more than 50% of the proximal reference segment. We can see also dissections, intimal dissections, medial dissections, major dissections or perforations, and of course, hematomas, serious hematomas arising from these dissections, and hematomas that are very difficult to treat. We can see thrombus, organized thrombus, like intraluminal masses or acute thrombus after placing a stent. And of course, we can see calcium. I think IVUS these days is the best way to study calcified lesions. You can see the arc of the calcium. You can see if the calcium is superficial, meaning that the calcium touches the lumen, and this is the very difficult thing to treat. And also you can see deep calcium, which is not so much of a problem. And then by doing IVUS in calcified lesions, you can select the appropriate way to treat IVUS. So, in conclusion, IVUS identifies anatomy, extent of disease, sizing, calcification, thrombus, dissection, underexpansion, and malapposition. And IVUS is, of course, associated with reduced MACE in PCI. So what is the problem? Well, it is two things, cost and education. Currently, we use IVUS worldwide like 8, maximum 10% of the cases that we do in the cath lab. I think we can improve that number, and also we can learn how to interpret the images of an IVUS examination. Thank you so much.
Thank you for this comprehensive and educational presentation. I think you made it clear that there is a lot to learn about IVUS. We need experience, we need education. And as IVUS comes, the same applies also to OCT and to FFR, as a supplement to the coronary angiography, it is meant to help us understand better the condition, having in hands a perfect angiography. I mean that quite often, unfortunately, we see angiographies that are obviously suboptimal. So intravascular imaging should not be an excuse or an alibi for a suboptimal angiography. And I find it quite difficult when I have a suboptimal angiography that I cannot trust to feel convinced about the report from the report of an IVUS. So the report of an IVUS should be come to our hands with the images too. We need the images too to interpret them ourselves. A comment from the audience?
Let me say that I agree with you totally, but this is the reality, that sometimes you have suboptimal angio images and you need the intravascular interpretation of an angiogram. This is not the right way to do it, but it's the reality.
I totally agree with that, but there are not only inherent limitations of the angiography, there are limitations that are connected to our capacity and the care we take when we take the angiographies.
Especially for left main disease, I think IVUS examination is essential.
we all agree that to report everything in detail. I mean, seeing the images, of course, is imperative because sometimes there are things that are not described in the report, but also we have to make it part of our practice that we have a report, a structured report for the IVUS or OCT imaging. So we have to have detailed reporting of the sizes of the reference vessel, of the MLAs, of the plaque characteristics also when we describe a lesion in every part of the vessel so that the ones after us can actually appreciate what has happened during the characterization of our patient. A quick question, Elias. You have a very lot of experience and also have worked in the CRF in the past. We know that the sizes that we measure is all relative. It depends in part also to the BSA, the BMI of the patient. So do you take that into consideration when you are actually doing an IVUS interrogation? And just to complement that, in the Excel trial, for example, we had different cutoffs for the optimal result of the PCI in the left main.
This is a good idea, and always you have to pay attention to these details, such as the BMI, different arteries for a small woman, different arteries for a big man. However, the most important thing is the reference segments of the artery itself. That is the thing. So you compare everything to the same artery. What is your distal reference? What is your proximal reference? And then what is your stenosis measurements?
And we know that, okay, there is a globally accepted limit of the 6 square millimeters for the left main. Do you still use the 4 square millimeters limit for the LAD, for example?
Depends. Depends on, at what part of the vessel are you. If you are in a distal part of the vessel, or a distal part of the LAD, then you cannot achieve 4 square millimeter cutoff for non-ischemic lesions. Then you have to lower your expectations. If you are in an ostium, then still, or in the proximal part of an artery, then yes, you use the 4 square millimeters cutoff.
I guess you agree also that when you want to perform PCI, do imaging instead of physiology, right?
Yeah, always. Thank you.
A short question.
Okay.
Elias,
Sure.
Congratulations for the excellent presentation. It is known that the picture for OCT are excellent. And, the question is, do you think that there are any condition or where the IVUS has a clear advantage compared to OCT?
No, but the principle is to use whatever you have available in the cath lab and whatever you know to read it. Read it right. If you have an OCT and you know how to read it, if you have Dr. Karanasos in the lab, then use the OCT. If you don't have the OCT, use the IVUS, make the correct exam, and then see what you
For example, the left main is a situation when the IVUS is considered better. Do you agree with this?
Well, it's more simple to read the images with an IVUS for the left main case. If you have an OCT, do an OCT. I mean, you can see the same, almost the same things. If I have to say, to pick something, like the right answer is, if you want to see better the plaque morphology, then use IVUS. If you want to see the lumen better for a stent or a dissection, then use OCT.
Thank you. Just a quick comment. I think that OCT is indispensable in Minoka cases. There, IVUS won't give you the solution. For all the other things, IVUS is equally good, in my opinion. But for Minoka, I think that OCT is of paramount.
I agree. So, sometimes erosions, ulcerations could be more easily seen by OCT.
Also, it might be a little bit more useful in case of ISR, but I mostly use IVUS in case of ISR. So, thank you.
Okay.
Just a comment on this. If you want to see stent details, usually OCT is better. If you want to see thrombus, OCT is definitely better. If you want to see details on the plaque, rupture, erosion, OCT is better.
So, in the question where the IVUS is better, is there an answer?
It's not better. Do you want to make a comment as an OCT expert?
If I may stand up a bit for the IVUS, I would use IVUS in an ostial lesion. With OCT, it's not always possible. Well, it is possible, but it takes a lot of effort to get a very nice image of the anatomic ostium, because you have to engage the catheter and then put some contrast. If you do the contrast in the cusp, then you will not always get a good image. So you need to have a lot of effort, several pullbacks in order to see the ostium. CTOs, you cannot actually use OCT, and when you want to spare contrast, then again you have to go with IVUS.
I think the comment was extremely appropriate. For the left main is purely osteal disease and very short left main, therefore IVUS in my view. When we are going to the bifurcation that represent more than 75% of the involvement, I think OCT, especially with the new 3D pictures, they are going to add better. And clearly, as I said, that CTO is, at least for guiding what we are doing, is for IVUS. Could be also in an extremely large vessel, when you have extremely ectatic vessel. And that's our, in my view. And one important thing is IVUS is not just one entity. IVUS HD is becoming a higher resolution. It's going to compete better with the OCT, while OCT is going to see much more deeply because they move the focal length point. So the competition should be also consider the level of the generation of the system we are using. The same with angio. Somebody was commenting about the quality of angio is extremely important. And so we needed to get the right comparison with the best machine that are available. And also IVUS is getting better and better in terms of resolution.
That's a very important remark because we have very different IVUS software and consoles. We have the 20 megahertz, we have the 45 megahertz, and we have now the high definition 60 megahertz. So most of the images that you showed were with the high definition or the 40 megahertz quality. So that's very different from the 20 megahertz where we lose a lot of the details. The high definition, as we just heard, is very, very similar to most of the characteristics that OCT also can offer us. So it's important to have this newest generation of IVUS software.
We do not use so much these, the 20 megahertz IVUS by Volcano, even though there were special capabilities like the chroma flow, the VH, or whatever. And I think it's a great luxury to be in a position to choose what is the right modality, especially in Greece, when you work in Greece, to do an IVUS or an OCT. I will be more than thrilled to have this opportunity that day.
Thank you, Elias.
The next